Well, good morning, and welcome to the second annual Saratoga Assistant Trainer Continuing Education Program. The sign-in sheet is by the door over here, so be sure that you sign in for each of the 4 hours to get credit for the time that you're here. We will be recording all 4 hours of this program to create YouTube videos, and I'd ask you to please silence your mobile devices so we don't get interrupted about that. Restrooms are just outside this building or over in the clubhouse. I want to thank Ninth in particular for providing the box lunches for today, and I want to thank Neuro for providing the room and the audiovisual support. So in order to stay on time for the videos today, I'd ask you to keep your questions until the end of each session, and we'll have some time set aside to talk about concerns that you may have on each topic. Our first 2 hours this morning are going to be spent listening to Dr. Gillian Perkins, who is a specialist in large animal internal medicine at Cornell University. Dr. Perkins attended veterinary school at the University of Prince Edward Island, Canada, graduated in 1995, and then did a residency at Cornell University. Following this residency, she has remained on the faculty and is currently Director of Biosecurity and is the medical director of the Equine and Nemo Farm Animal Hospital. Dr. Perkins is a faculty advisor for the student chapter of the American Association of Equine Practitioners. She leads many courses in the college, including large animal neonate course, equine specialty rotation, large animal medicine rotation, equine sports medicine, and her research interests are mainly in vaccines, pathogenesis and diagnosis, and testing of infectious diseases such as equine herpes virus 1 and salmonellosis, along with immune response to infection. So our first topic this morning is going to be Gillian talking to us about infectious control at the racetracks. Dr. Perkins.
Well, thank you, Dr. Palmer, for the introduction. I'm happy to be here today. I would prefer to be here on a race day to see all the beautiful horses going around the track, but more prudent to give talks to trainers on the day of no races. So today I'm going to talk about infection control at the racetrack and how it's important to the racetrack and the trainers, and how each individual person can take action to help with managing infection control at the track. And I think it's pretty obvious to everybody here, why infection prevention is important, especially at a venue like the racetrack. And many of us, first point to the fact that we would like to race horses, we'd like to earn money, and if the racetrack ends up being closed and horses cannot compete, then all of our livelihoods are affected by that. But I think we also have, the horse at heart, and we love horses, so we would prefer them not to get sick. We'd prefer to not get many horses sick and to care for them in that way. So our love for horses and the races make it very important for us to control infections. A few years ago, I was fortunate enough to go to Hong Kong and visit the racetrack there, again, a day that there was no racing. And they have a very impressive infection control program there, which I was very interested in, as they're always flying in horses from many different countries on many different occasions. And actually they have multiple isolation barns. They open up the track for one so-called country or isolation barn at different times of the day for training. It was a pretty elaborate setup, and it was an eye-opening experience for me. So in 2018, what about infectious diseases and these outbreaks? It seems like we see maybe more of these outbreaks, or maybe the media just puts it out more, and so do our cell phones. So there's a lot more dissemination or discussion of these outbreaks that goes on quickly. And then perhaps some people have developed sort of what I call almost a zero tolerance. So any sort of infection, they're not really willing to take, which is maybe a little bit unrealistic in our world. And then, it has a huge impact on all the horse people involved. So we do need to work on sort of disaster preparedness and prevention to stop these things from happening. There's excellent resources and many resources available to you online. And I'd like to first recommend the Equine Disease Communication Center, which is put on by the American Association of Equine Practitioners. It's available to everybody. In fact, you don't need one of those silly passwords to log on, and you can see all this information. And they have things like outbreak alerts, disease information to give you an idea about kind of things like strangles and herpes I'm going to talk about today, biosecurity tips, which there's some excellent videos on there, special for horse trainers at racetracks, so all kinds of stuff. So this would be an example of them reporting out instances that have been reported in New York State over the last 30 days. So there has been Eastern equine encephalitis reported in Oswego County just, I guess, a few days ago, August 17th. There has also been West Nile reported on August 8th. So that tells us these diseases are present in our state and we need to be vaccinating for them. And then on August 2nd, there was a concern for herpes that was not confirmed at a later time in Farmington, New York. So this is a good way to find a good source of information where they say whether the disease has actually been diagnosed or not, or whether actually you're just listening to the rumor mill and maybe things aren't as bad as they seem. So this is a really good place to look. And like I said, they have lots of other information that's helpful to you. And I really recommend a video in this biosecurity section for horse trainers, which I have some pictures in my talk today as well. So there are many different infectious diseases, and the goal of talking today is not to go over all of these diseases, because actually in the end, most of the things you do to prevent these things, you do the same sort of things for all of the diseases, and it's really using good infection control principles. Cleaning, disinfection, washing your hands, things like that. But things that we're kind of majorly concerned of, could involve the respiratory tract, like equine herpes virus, influenza and strangles. Could involve the gastrointestinal tract, where we have horses with diarrhea, like salmonella or coronavirus. We could have neurological diseases, like EHV1. I don't list Eastern encephalitis and West Nile. Those are both spread by mosquitoes. So mosquito control would be our way to prevent that. And then in my world of veterinary medicine, we also worry about surgical site infections, wound and catheter infections from multi-drug resistant organisms, and things like that. So there's lots and lots of things to be concerned of, and probably what you guys have thought about in your lives has been herpes, flu, strangles, and then some of these other things can play a role as well. Certainly there are conditions that are zoonotic, which means that the infection can go from people to animals and animals to people. And luckily, most of the horse respiratory viruses we don't get. So like flu, is something that in horses, it's special to horses and we're not going to get it from our horse. But there are certainly other conditions that are of concern, but not that common in the horse world. So let's talk a few seconds about disease transmission, because this is all how we need to break the cycle of transmission to prevent infections. So we know fecal-oral is a main route for infection, and this picture is cute and funny all at the same time. The foal's eating the mare's manure, which is important for the foal to develop its own bacterial flora in its gut, but it could also be eating some bad things there as well. Now, we know we don't all go running around eating poop, or we hope we don't, but we do know that poop can kind of get everywhere, right? So feces can be on the stall floor, we walk through it, we walk through the barn, we go to the place to eat lunch, and then we're spreading these things around from one place to another. So I don't think any of us go and actually try to eat poop, but we do find that, it gets contaminated to the area, and potentially we're taking our hands in that area, wiping our face, and some is indirectly making its way to our mouth. Disease transmission, we certainly have vectors. I talked already about Eastern encephalitis and West Nile virus that's in the state. Those are spread by mosquitoes. And we also have vectors like this caddis fly that leads to Potomac horse fever in our population. And years ago, we really felt like the racehorses that are boarded in the stable, how are they going to get this? These flies are mostly out in the pasture. Well, actually, these flies sometimes are attracted to the lights that we have in our barns, and they fly around those lights, fall into the feed buckets, and then the horses are eating them and getting sick from that. So, so turning off those lights at night could be important to not draw all these flies that are out in the environment. Nasal secretions and aerosol transmission is very important. So you think about flu, where the animals are coughing and sneezing all over the place, so it spreads far and wide. And that also means that if, for example, a horse or a person was sick with something that was aerosol transmission in this room, then, the air in this room becomes contaminated, and everybody potentially is exposed to that. So if you're sneezing the whole talk today, then, we could be sharing some viruses here as well. And then we often think also about the nasal discharges then contaminating things and being more of a direct or indirect contact to other animals, and we'll go through that. So indirect transmission is also considered fomite transmission. So that means, say, the nasal discharges drip onto something, the organism can live on that object for some amount of time, and then, you and I pick it up, or another horse sniffs at it, and then that horse can become infected. So example would be, here we have a twitch on a horse's nose. If that horse has a respiratory virus, it can contaminate the twitch. I take the twitch to the next horse, and lo and behold, I'm spreading the disease. Another thing is the horse with maybe a virus in its nose, and it's nuzzling up to me while I'm working on it, and then I go to work on another case, and the next horse is nuzzling up to me and then becomes in contact with the virus then. So my clothes, the horse's halter, the lead ropes, and water buckets are something to really think about as well. Really shouldn't be sharing water buckets as, nasal secretions are dropping into those and spreading to other horses as they drink from them. And I often say, we'll talk about strangles later, but I often tell the students, if you want to know if a horse is draining a lot of stuff from strangles, put the water bucket down low in the stall, and when the horse is drinking, the nasal secretions fall out in the water, and you can see the little balls of pus in the water buckets. So yeah, you definitely don't want to be sharing water buckets. And then, as we're cleaning the stall, we can become contaminated, and also, our pitchforks and all that sort of stuff. The horse is sniffing at it, potentially has a virus, and puts it onto those things. So that's fomite, where your inanimate objects become exposed and can travel the organism around to other things. So we've already talked a bit about water troughs, and then also as strangles, where they have infections in their lymph nodes under their chin, and the young horses are all putting their chins over the fencing, and then that organism can persist a little bit in the environment, so that area can become contaminated as well. And their halters for sure, as things drain on their halters. So, how can I prevent illness in my horse or horses? And there's some few main things which I'm going to go over in a few minutes, but, I don't think I'll read this list, but we'll just start into kind of each of these things. And I should start by saying some of these pictures I've taken from the Equine Disease Communication Center website, where they have a great YouTube video that's for for the racing industry, and so I've taken some of these pictures from there, and I encourage you to watch that video as well. It's done really well, and it's only about 5-6 minutes, way less than my talk. So basically, separation of new animals is an important thing, and that can be a really big challenge, and also why, the racetrack and doing horse competitions is a challenge and a high risk for animals, right? We're bringing animals in and commingling them. But if your horse is going to the track and then going back to the farm, potentially separating the ones that are coming and going into a separate area. And that can look many different ways to you. So it could be that you actually have, a beautiful little isolation building where you can only keep that animal or a few others, and they're completely geographically separate from everybody else, although most of the time that's not happening. People don't just have extra barns everywhere. So I'll go through some more examples of, setups for that. But one thing in our separation or quarantine time for the animals going into this area will be to watch them for fevers. So that means we need to be taking their temperature each day. Check their nose for, discharge or snotty nose, whether they, stop eating, whether they're coughing, or whether their manure has a change in consistency. And in general, the recommendations are about 2 to 3 weeks to do this separation. There are many ways to do it, like I've said. This is an example of kind of how we might do a modified isolation in our hospital. There's some times where, our isolation building may be full, or we're not sure if a case is infectious and we still need to do a lot of management. And you can see this isn't perfect, right? We'd prefer to have a stall at the end of the barn, maybe a separate entrance, so that animal can be completely cordoned off. And remember, if the horse has something that's aerosol spread, the air in that entire area will be contaminated. So it's not really advised for things that are aerosol spread. So we can cordon off the area. We use a lot of kind of caution yellow tape. We make a designated area for people to walk through. So we have a foot bath, which really sets people's minds like, hey, I'm going into an infectious disease area. We're often wearing what we call personal protective equipment so that our clothes don't get contaminated, and that can be either like a Tyvek suit or coveralls, but they should be only one use because you can't get in and out of them without contaminating them. And then we want to have, separate equipment, buckets, pitchforks, garbage, manure disposal for that area. And remembering that, we don't want to take this horse out of here and walk it all over the place and then contact other animals as well. So those are some ideas for, setting up an isolation. You don't necessarily have to have a completely separate and distinct spot. You can make your own sort of area that you call a separated, isolated area. And here's another picture from that website where they're showing, they have multiple horses, but now they have different equipment for each stall. And then this is the kind of newcomer, didn't necessarily get separated in a separate building, but it has its own stuff, and its own gear is, designated by a little red tape on there, so not to be used for sure with other animals. All right, so aside from, trying to quarantine new arrivals or ones that have gone off to competitions and been exposed to others, is a general health care plan. So equine vaccination is very important. I just mentioned that West Nile and Eastern have been diagnosed in New York State this summer, and that means that we should be vaccinating for that, and that is considered a core vaccine by the American Association of Equine Practitioners. So whether your horse is competing or whether your horse is a backyard horse, we should be vaccinating for things like tetanus, Eastern encephalitis, West Nile virus, and then rabies. Then when you're competing with your horse, then we're looking more at things like risk-based vaccines because they're mingling with other horses. And so influenza, herpes, and strangles are all recommended for the racing horse because of the exposure to other animals. Now, they're not 100%, and the vaccines obviously do have some cost to them. However, they cost way less than, closing down the track for an outbreak or for the medical management of these disorders and things like that. So well worth doing. And then other health management things, right? A healthy animal, a healthy kid can fight off infection. So having a good nutrition program, keeping up with the deworming program, and good dentistry program as well is important. Another thing is to know the status of your own horse's health, and that can be done by taking a temperature each day. You are all horsemen here and know your horses very well, and therefore, trying to detect something that's going on in the horse that you can't see from the outside. So rectal temperature can be very important. Taking it all the time lets you know what your horse's baseline is and should it go above that or even reach a fever. So many horses sit around 99.5 every single day. So if your horse is looking like 100.5 or 101, even though that's not a fever, that might be concerning to you. So taking their temperature, recording it, and then, what should you do? Oopsie, I think I'm a little bit mixed up in my slides. We'll go through what we should do if we detect a temperature in our animal next. Or before that, I'm going to talk about washing your hands and applying hand sanitizers. So basically, we'd like to keep ourselves clean, our equipment clean, the horse's surroundings and stalls clean, and really our hands are kind of what kind of goes everywhere. So, in a veterinary hospital, it's extremely important. In a human hospital, it's extremely important. Now, we don't have all the pathogens kind of focused in one place in a barn. However, washing your hands before, going from one animal to another or going from one barn to an area to another is an important thing to do. It's hard to have sinks in every corner of the barns, so therefore hand sanitizers are very effective. And you can have them put all over the place to make it convenient to be able to apply them. So just putting a good dollop on there, kind of rubbing your hands through, letting it dry, trying to expose all surface of your hands to help disinfect your hands and prevent transmission of various disorders. And then cleaning your own personal items. And I know in my world, we're using our cell phones all the time. And, we're with our patients, people are calling us, you guys are very busy as well, getting interrupted all the time with these texts, picking up our phones with these hands all the time. So I would ask, are you cleaning your cell phone once a day? Are you cleaning it once a week? Are you cleaning it more or less than that? Disinfectant wipes can be very effective at cleaning cell phones and are very safe. You just don't want to get the phone super wet, so I just use some disinfectant wipes on my phone. And thinking about other things when you're going from one animal to another. So to talk a little bit more about cleaning and disinfection, we're thinking about the stalls. Obviously we're removing manure and urine every day from the stalls, but probably there needs to be some sort of cleaning disinfection on a routine basis, whether that's once a week, once every 2 weeks, it can be fairly important. So what you want to do that is sort of remove all the material from the stall and then wash, clean and scrub and remove all the sort of leftover organic material. Once that is done, then you can apply your disinfectant, and you need to use the proper mixing of your disinfectant and leave it on the surface at the labeled time that particular product says. So you should follow the directions, and that also understanding that drying can be important in the overall disinfection process of the stalls. So I've put this website available here as well. This is my go-to place for infection control concerns and information, and they have a little booklet that's called Disinfection 101, and they talk about how to do these things. And this is the Iowa State University Food Security and Public Health website. It's very helpful, has a lot of information. And you may ask, like, what are the disinfectants that I should use? And there's a nice chart in there of the different types of disinfectants. I don't want to get too crazy about all this with you, but generally most over-the-counter things, bleach is good as long as you don't have a lot of organic material, but we already talked about how you're supposed to have that cleaned out first. And I'm just following the directions for those. So I want to go back a slide and say cleaning and disinfecting your horse trailer can also be important. You want to use your own equipment to do that, not necessarily if a track provides you, you unload your horse and there's stuff there for them to help you clean out your horse trailer, because really then that's going in everybody's horse trailer, right? So you'd want to use your own equipment to clean and disinfect your horse trailer. And I'm not necessarily saying every time, but there probably should be some sort of schedule that you're following to clean and disinfect your trailers. All right. I'm just going to go back and say, okay, yep. So basically, we mentioned taking horses' temperatures on a regular basis. And really, how do we know that a horse has a fever? And I think many of you would recognize your horse being sick. They're often dull, they may not eat well, they have a temperature over 101.5, although sometimes there's very minimal changes in their clinical signs. So sometimes people may not notice anything wrong with the horse and you're taking its temperature and it is a fever. So just trying to reiterate that taking the temperature can be an important part of your daily routine. So what should you do if your horse has a fever? I would recommend seeking veterinary attention. It's very important that you do this early, because early detection of an infectious disease can help prevent the spread. So if you take action right away, you can stop something more major from happening. Sometimes there's a lot of things at stake and you don't really want to know that that fever is happening. You'd like to hide that under the rug. But I would encourage you to really seek veterinary attention and then institute biosecurity practices right away to stop this from becoming the so-called perfect storm or outbreak situation. And at the time, diagnostic tests are helpful. Basically, it informs us the treatment of the sick horse. So what should we do for the horse? Should it get antibiotics? Should it get something else? So it informs the treatments, and then it also informs the biosecurity measures. So if I know it's one pathogen over the other, I may know, does it live in the environment or just in the horse? Do I have to disinfect a lot, or is the sun going to kill the organism? Is there a long incubation period, or is there a short period? How long is it going to shed? So if I know the diagnosis, then I can make the infection control plan moving forward from there. So for a lot of the respiratory conditions, I have a picture of us doing a nasal swab. That can be done quite quickly, sent to a diagnostic lab. If everybody is very concerned about an infectious respiratory condition, the sample can be statted, and we could get the results within a 24-hour time period. So things can go very quickly. Relationships between your veterinarian and diagnostic labs can be really helpful in coming up with a diagnosis quickly, and then an action plan. I've talked a little bit about personal protective equipment and using separate cleaning things, and I don't think I'll go into too much more about that. But there are a lot of temporary things that you could use in an outbreak situation. All right, so in general, good infection control practices start with good overall healthcare plan for your horse. So vaccination, deworming, and good nutrition. Another thing was using your own equipment, bridles, water bucket, horse trailers. Using separate buckets for manure disposal versus feeding. That may seem silly to you, but I was in a room of veterinarians and was asked by a veterinarian that question. I think we can all agree that, we wouldn't want to eat out of our toilet bowls, so we don't really want our horses doing that. We can minimize contact with horses from other barns. We should be washing our hands. There are many online resources available that I would invite you to explore. The Horse has many articles. They have things on how to handle a disease outbreak. The University of Colorado with Paul Morley has some excellent videos on preventing infectious disease in horses when traveling. So he goes through some of that as well. The group at the University of Guelph has excellent information. They call it the Worms and Germs blog. You can read what this gentleman here, Scott Weiss, says about various biosecurity things. They've had in the past a program where looking at, you can go through a checklist and see, does your farm do these things that show you're doing a good infection control. So it kind of gives you a score at the end and gives you some ideas on how you can improve things. I have a long list of other infection control websites here, and I can provide, this is on the video here, and then also I can provide this to Dr. Palmer, but there are more of these coming available all the time, and I think, and they've been very user-friendly for everybody. So with that, I'd like to open the floor to any questions. I wanted to see if people had ideas of infection control, issues that they've come up with, things that they struggle with on the track. So I would take any questions, although I doubt I will get any. So I'm going to stop for here. Yep. Mm-hmm. Mm-hmm. Yep. Right. Mm-hmm. Mm-hmm. Okay. Mm-hmm. Mm-hmm. Right. Mm-hmm. Right. Uh-huh. Okay. Yeah, so yeah. So for the, mm-hmm. So the comment is that the information given here today applies, but maybe there's a lot of differences between what I've talked about today and what applies to this racetrack. And I would say that one thing about infection control is often people just need reminders. And it is really just the basics, and the basics do make the biggest difference. So I think often people think infection control could be really sexy, but it really isn't. It really is about washing your hands and doing the basic things. And then if you're using large transporters, then, are you asking them, hey, was this disinfected previously? What are your protocols, Mr. Truck driver? What are you doing to prevent infection in my horses versus the other horses? So you could increase the bar in some of these other groups that are providing services to you as well. So, yep. Right, right. Mhm. Right. Yeah. Right. Yes. Mhm. Mhm. Right. Mhm. Uh-huh. Yeah, so it's knowing your audience, right? And then who do you want to be trained? Do you want do you want your trainers trained, or do you want your workers trained, right? And the workers do need consistent reminders usually. Mhm. Mhm. Yeah, no, fair enough. Mhm. Right. Mhm. Mhm. Right. Mhm. Mhm. Right. Right. Mhm. Yeah, and outbreak management is a whole different ball game, right? And who's in charge of that and how they do that. Mhm. Yes. Mhm. Yes, right. Mhm. Right. Mhm. Right. Mhm. Right. Mhm. Mhm. Right, right. Mhm. Are you guys done with the videoing? They're good. right? Because I don't think they can hear you guys unless you have a thing.
Personally, I have a farm with 300 horses on it, and that farm has 13 barns with various, including a quarantine, 2 international quarantine stalls and another quarantine barn, just domestic, So, those things they're possible, but, at a racetrack, the horses are here to race.
Yes, right. And they're going to commingle. There's no question about
Yeah,
that.
and you can't, of course, if there's an outbreak, but when's the last time we had a major outbreak?
Well, we've had a couple of Equine Herpes virus outbreaks down at Belmont Park over the last 4 years. A couple of them.
But here,
I think Saratoga, we had 2 cases of infectious disease here in the last 2 years that were unidentified causes that died of acute diarrhea. So
It's
we're
not.
not immune to it.
No,
Right.
no, I don't mean that.
And then the
I don't-
standardbreds
I'm
have
just
had
saying,
the
how do you
strangles and
deal
stuff,
with it?
too.
You have to have observant people, basically.
Yes.
I
And that was the
understand.
message, right? Like, yeah, tell somebody right away the horse is
Everybody
sick.
takes, but everybody takes, basically what I know, every horse's temperature once or twice a day.
Yeah,
Control of it.
right. Yeah. Yeah,
Routine.
right,
But here we do it, someplace else.
right.
That's the problem.
Right. Yep. Yep. Yeah, and that's the nature of the business, right? That's not going to change. Horses are coming from everywhere, and they're all going to kind of, be commingling out there. And you can't. There's not enough time anyway.
Worry about a starting gate, well, then you gotta worry about every horse that ships in here, and in the horse band they were in, more importantly, because the horse band is the most exposed environment they could possibly be in.
Right.
And they're in it usually for a minimum of 2 or 3 or 4 hours, even if
Right.
here is basically 4 hours, and
Right.
15 hours. There's still little done to prevent that spread in those
Right.
environments. I have a gooseneck, but we disinfect it after we use it. But that's me.
Right.
Commercial vans, they dump the manure down there and fill up the tanks and dump it.
Right.
Sally is probably doing that.
Uh-huh.
I mean, yeah,
Right.
but Sally's done it.
There's probably variation among different, just like there's a variation among
Right.
trainers.
Right. Yes. Yep.
If you look at the Sally's van interior and look at the two cases, there is several diseases. But Diane White said it looks
Right. Right.
and the consequences of it.
Right. Right.
That's not the way it works.
But I mean, I think we're trying to prevent the major problem, but interestingly enough, we know this is a big risk factor, but very rarely does a big problem happen. Which is excellent, right? We bring horses from all over, and in you go. But so what's happening is going pretty well, and every once in a while there's a blip on the radar, which is what there's going to be, and how do you respond to it is probably the critical phase. Yeah.
Well, one of the things now we have
Uh-huh. Right.
Cornell certainly is.
Right. Mhm. 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 But I can give you a little more meat and potatoes on strangles and herpes. But yeah, just plow through. Okay. Per- All right. Mhm. What do you guys want first, strangles or herpes? All right. I'll go with some strangles. All right. So I'd like to take this opportunity to talk about strangles. I'll start out by saying that strangles is an infection caused by Streptococcus equi subspecies equi. So often we kind of take that long name and just call it Streptococcus equi or strangles. It is a gram-positive organism, which I'm showing here on the screen, which means when we do a gram stain, we see that it is purple. And then it has, it's a cocci shape, so it's round, and it appears in pairs. So we can grow it quite easily in culture. And, you know, there are a lot of reasons why strangles is a problem that you do not want to have. So I often joke, like influenza, it's bad, the horses get sick, the incubation period's really short, it kind of goes through a barn in a very short order. Now strangles is a little bit different, everything just takes a whole lot more time, and the horses are sick for a longer period of time and don't do as well, lots of complications. So the incubation period for one makes it challenging, it's 2 to 3 weeks, so that's why a lot of these sort of isolation things are set at sort of a 2 to 3 week time frame, because they can have been at a show and not show any clinical signs until 2 to 3 weeks later. The duration of illness is also kind of long. So they'll have a fever, they'll develop these lymph node abscesses. It'll take a couple weeks for those to kind of like drain and all that sort of stuff. And then they're actually even going to be shedding for even longer than the clinical signs take. So when I started as a veterinarian about 20 years ago, you know, the rule of thumb was like 4 to 6 weeks after they're done with their clinical signs, they may still be shedding. And I think that still holds true, but we try sometimes to diagnose them out sooner than that. And then they have a lot of complications. So a lot of different things can happen when a horse gets strangles, and I'll go through those complications with you. And the final thing is that there's this chronic carrier state. So the horse may have it inside their guttural pouch where it hides, and it can be there up to 2 years. Most of the time we feel like maybe a horse is what we call a chronic shedder, maybe up to 6 months or something like that, but it could be a really long time. So one report kind of followed a horse over time and it was up to 2 years. Now those are rare, but those horses that are chronic carriers, not showing any outward signs, keep exposing other new horses and getting those horses sick. So strangles is overall a real pain in the neck, so literally. So, this is, we'll go through, and then also it persists in the environment a little bit. And so if there's nasal discharge, there's snot, and the bacteria is in that snot, it can fall onto the wood. And somebody studied this and found that they could still grow it off of that wood like 63 days later at a specific temperature, so cold temperature. A little bit warmer, it lasts less time. And then moist environments like those water buckets again can be even longer. So the take-home message on how it persists in the environment is that you really can't count on the sun on taking care of strangles. You need to kind of get the scrub brush out and your disinfectants to clean it. Yep. Okay. So the question is about vaccines. I was going to get to vaccines at the end, so I'll save it for later. So we have the different clinical signs of strangles start with a fever and a snotty nose. So, and usually when we talk about the snotty nose, it's kind of white, and sometimes people even report kind of a greenish color. And it's really thick. It's not the serous, like a respiratory virus is usually sort of serous and clear. This stuff is chunky, white to green in color. And then sometimes they'll have a cough, and other times this is looking underneath the horse, so I'm underneath, shooting up underneath the chin, and so the lymph nodes under the chin are big. So this is clipped area here, and if I was standing beside the horse and looking at the horse, their throat latch region starts to look very big, and that's because those lymph nodes in there are enlarged. So this is a horse with more advanced strangles. It's always hard to get pictures of this part of the horse because I'm underneath them, shooting up under their chin. So this is throat latch region, and these abscesses are draining. So there's pus, and it's open, and we've been cleaning them and flushing them, and this is a more advanced case here. This picture here shows that the horse has all kinds of different lymph nodes. So the little black circles are lymph nodes. So these are the ones we see underneath their chin, the mandibular lymph nodes. These are the ones, they're called retropharyngeal lymph nodes, and they sit in the floor of the guttural pouch, and I'll show you pictures of that in a few minutes. And then we also have lymph nodes going down the horse's neck. And so I sometimes joke, when we have strangles, we learn where all different lymph nodes are in the horse, because many of them can become infected. So we can have ones on the side of their neck here. We can have ones up around their ears that can abscess, and then that abscess drains. And remember, the abscess purulent fluid is infectious, and infectious that means it can infect other horses. So when we have those fevers initially in our horses, we're always worried about respiratory viruses. And then we're also worried about strangles, which is a little bit harder to diagnose sometimes until you get those lymph node swellings. And then, if we're shipping horses a lot and shipping them long distance, sometimes we're also worried about them having shipping fever, which is a severe pleural pneumonia, which really needs advanced therapies. So when we have suspicion for strangles, the diagnosis is tricky sometimes and easy in others. So basically, there are many ways we can do it, but the purulent material, if I have pus and I send that to the lab, they're pretty much going to tell me that's strep equi or strangles. So that's pretty easy. Other times where I just have lymph node enlargement, it's not draining yet, then there's other tests that I need to do to be able to confirm this. So, so when we're doing things like nasal swabs, those are good for respiratory viruses like herpes and rhinitis and flu, but they're not so good for strangles, because strangles hangs out in the back of the throat and not down at the tip of the nose. So we have to do more testing than that. So the nasal swab itself is not a good test. If you do that and it comes back negative, it doesn't confirm that the horse does not have strangles. So we have to work a little bit harder. So if I got this pus from the draining lymph node, that'd be pretty easy. The test would come back positive. And then other tests are things like doing a nasopharyngeal swab, so using a long swab that goes to the back of their throat, doing a nasal wash, a guttural pouch wash, and then Dr. Timoney at Gluck talks about, getting at their tonsillar crypts. Haha, we're probably not going to use that diagnostic test. That's in their mouth, under their tongue. So this is an example of how they do a nasopharyngeal wash. And basically what we're trying to do is get more nasal secretions and get back in the horse's throat so that we're more likely to diagnose the condition. So this is an example that was published by Ashley Boyle at the University of Pennsylvania, where she's got a little tube and she's squirting about 30 to 50 mils up the horse's nose. And then this person over here is catching it into a rectal sleeve, all the fluid that comes out. And hopefully you'll see some good chunks in there from the nasal discharge, and you send that to the lab, and that's more likely to confirm your diagnosis than just a straightforward nasal swab. I personally don't use the rectal sleeve for this technique. I use a little Ziploc bag with kind of a wider mouth. And you can also see that, we're trying to prevent transmission from one horse to another, so they're wearing the personal protective equipment. So this test, or guttural pouch lavage, seems to be the best test, unless you have pus, to be able to diagnose the condition. So when you're scoping the guttural pouches, it can be a little bit tricky, but you want to get a sample of fluid from that guttural pouch and send that to the lab for your testing. So it's not straightforward, and of course, once we're getting the scope out, it's a little more expensive to be able to do this test. But the good thing is with the scope, you also get to see in the guttural pouch and see what those lymph nodes look like, and they're very characteristic looking when we're in there. So if you see that, that's also supportive, and then hopefully your test supports what you're thinking as well. So once we've got those samples, we send them to the diagnostic lab, and there's two things you can do. One is you can culture it, meaning you just grow the bacteria on a petri dish, and then the other is to do a PCR, which is polymerase chain reaction, which is looking for the DNA of the organism. So the DNA test is extremely sensitive, meaning there could be like 10 organisms in there, and if I have it in my sample, it'll come up positive. So it's a pretty good test for strangles. Interestingly, this is just showing us paper where they're looking at things, and the horses had a fever before they ever could find the organism in the diagnostic tests. So there's some idea that the fever starts, the horse starts shedding a day or two afterwards, and so if you catch that case initially, then hopefully you'll prevent spread to other animals on the farm. All right, so some of these things we'll go through pictures of what the horses look like. And so here again, we have some swelling under the jaw and draining lymph node. Here, once they've developed a soft spot, sometimes we've opened those up, but pretty much if it's got a soft spot, it's going to drain shortly. I wouldn't advise trying to do this trick at home because this area of the horse is very important. There's a lot of arteries, veins, nerves. Don't want to mess with that. So a lot of times you'll just be hot packing those to help them come to a head. So in an outbreak situation, sometimes you're thinking about the in-contact animals and your barn's closed now because you feel like you have strangles, and you're going to start temping all your horses on the farm. And so if you have one that develops a fever, probably putting that animal on antibiotics right away before they develop any clinical signs will stop the disease process. And so that is something that taking those daily temperatures is quite helpful for. For the clinical case that's sick, in general, you kind of want the disease to take its course and drain, and unless they have complications, you don't really treat with any antibiotics. So you want those lymph nodes to just drain. We try not to treat with antibiotics. We give them some bute or other anti-inflammatories. You can hot pack the lymph nodes to help them come to a head. Sometimes, as a veterinarian, we might open them, but we try not to because it's a little bit dangerous. And then we give them soft feeds because it's really, their throats are very irritated. Sometimes they'll lose a bit of weight throughout this process. And so we'll try to encourage them to eat as much as possible. And those anti-inflammatories is important to make them feel better and help them eat too, help the fevers. So this is a picture of a horse's throat, a normal throat, right? We have the epiglottis here, the retinoids here, the vocal folds here. The dorsal wall of the guttural pouch looks good. We can see the airway, which is right here, very easily. We have normal lymphoid hyperplasia, like a young animal. And then in this view, it's sort of like the scope is positioned at the same place, but now we see that this whole roof of the dorsal pharynx, or the upper part of the pharynx, is, it's not collapsed, but there's a space-occupying mass there. So now I can't see the airway, and the horse is essentially being strangled, and that's why it's called strangles. So this horse would be having difficulty breathing. It would be making a noise as it breathes, quite dramatically with every breath. It may fall over because it is short of air, because it has an upper airway obstruction. So sometimes these horses are critical and need to have a trach tube put in to bypass that upper airway so that they do not strangle. So this horse had a trach tube placed. Now the horse can breathe through this trach tube, and then we can address the problems in their throat next. So basically then, what this is the top of the throat, and it's falling down because there's a big mass there. It's not really falling, something is there, and it's the lymph nodes that's enlarged. So if I go into the guttural pouch with my scope, and then I look in at the floor of the guttural pouch, it should look like a bowl. So it should go like a nice bowl, nice and empty. In this picture here, we see that it's not a bowl. It's got a soft tissue mass that's like kind of circular, nodular, and it also has this sort of purulent material or pus right here. So this is classic for strangles, and this is that retropharyngeal lymph node that I showed you initially, which is buried deep within the horse. I can't really feel that. So this is the retropharyngeal lymph node that's infected and draining some pus in the guttural pouch, and also this would be affecting the horse's airway. As time goes on, sometimes horses develop what we call chondroids, so we're still in the guttural pouch, and the chondroid forms, and basically it's just dried pus. So the dried pus in there just sits there because it doesn't drain out. And again, this dried pus has a bacteria in it, and then sometimes, you'll see some nasal discharge, and the horse is infectious to others. So these cases are a little bit more challenging. This one here, I might need to do more aggressive therapies, like flush out their guttural pouch with saline, maybe even put some antibiotics in there. But I want to be extremely careful what I infuse into the guttural pouch, because just like under the chin, there are many arteries, veins, and nerves that are very important to the horse, like your carotid artery, and things like that. So we don't want to cause irritation in there. If we irritate those nerves in there, the horse won't be able to swallow. So we don't want to inject things in there that are caustic or inflammatory. We want to be very careful about that and try to flush out the chondroids. A picture I haven't showed you is sometimes we try to get into the guttural pouch and it's just chock full of pus. So we're going in, we can't even see anything, it's just this pool of pus in there. And again, the same sort of management strategies apply, where we flush it out with fluid, we maybe put antibiotics, and we have to do this, multiple times. It doesn't get better in one day. Just like I said initially, strangles is annoying because it can persist for a long time. So these take a while to clear. So there are other complications associated with strangles, and this is another reason why it's a bad thing to have on your farm, is that we can have Purpura hemorrhagica. So these horses, it's usually after an infection, so maybe you've had an outbreak and it's like a few weeks later. It's not usually at the beginning. The horses develop a high fever. They'll have swelling of their legs, they'll have swelling of their belly, and it'll be hot and painful. And so if I look in their nose, sometimes I'll see these petechia, which is just because we have their blood vessels are leaky because they have this immune-mediated blood vessel problem or vasculitis. So unfortunately, it's not just associated with the infection, it also happens sometimes secondary to the vaccine. So that is a complication of the vaccine. The other thing is this requires kind of treating with steroids, and it's really hard to treat and can be quite bad. So this complication is, again, another pretty bad thing for strangles. Another thing about strangles is that we call it bastard strangles, where horses get abscesses in other parts of their body. So this is a Belgian horse that was bought at sale a few weeks previously. It started to colic. It came into the hospital, had a splinted, kind of tucked up abdomen. We could feel an abscess on rectal exam. We could see it on ultrasound. And when we did a belly tap, we could tell that it had a lot of inflammatory cells in there. So that had a bad prognosis. Sometimes we could treat these cases with long-term antibiotics. Sometimes we could take them to surgery. But pretty much this here is the abscess. Sorry, we're getting close to lunch, but this here is the abscess, and everything's sort of sticking to it. So it's never an easy surgery. I kind of say, you'd think, oh, well, an abscess is like a little grapefruit. I can just pop it out of their abdomen. They'll be fine. But actually, the grapefruit type abscess thing is just stuck to everything else in there. So the surgeon, as they try to pull the other things off of it, may, rupture an intestine, and then that's the end of the horse there. So this is a post-mortem picture, and you see the purulent material or pus draining from there. There are some myopathies that happen that are quite dramatic, where their muscles become really necrotic. So that's not very common, but does happen. And then actually, we can have some brain abscesses in horses secondary to strangles, which again is not very common. So you think about their guttural pouch in this image is right here, and it's pretty easy for it to extend up or for blood vessels to take it to the brain somehow. All right, so you've diagnosed your horse with strangles, then you've gone through some management, hopefully not had too many complications or spread within your farm, and now it comes to the end and you're like, okay, my farm's been closed for a while, we want to get to business again. How do we get an animal to be considered negative? And this is a big challenge. And I'd say the first thing is always to be patient and wait. Sometimes people are like, just start doing the tests, Dr. Perkins. I want to be out of this. My horse looks fine. And I start running the tests and it comes back positive. And so it just means I have to run more tests and spend more money running tests instead of waiting for time. So I do recommend waiting and then doing some of these tests that are recommended by various groups. And they do involve those tests I described earlier, a nasopharyngeal swab, a nasopharyngeal wash, or a guttural pouch wash. And you can do culture in those and PCR. There is a consensus statement that says to kind of do these once a week for 3 times. And if they're all negative, then you're good to go. This is kind of expensive for people. Depending on the various situations you're in, you can, decide what works in your given situation working with your veterinarian. So we talked earlier about the, asymptomatic carrier. So here's your healthy horse. Doesn't look like there's anything wrong, but maybe it carries strangles. And then also the horse that has the persistent guttural pouch infection, maybe drains some pus every once in a while and infects other animals as well. So those horses, again, we want to get into their guttural pouches and get these samples to kind of decide, is this a carrier horse? And then do I have to treat this horse so that he no longer, continues to shed and get other horses infected? So this is kind of a busy slide, but really just showing some work done by the group at Penn, showing that really, that nasal wash idea, that was pretty good, but we really feel like the best thing to do is to scope the horse's guttural pouches so you can see what's in there, and then take your sample and send it to the lab. If you see the lymph node enlargement, if you see the pus, you know you have strangles. So it may reduce your need for repeated sampling over time. Titers for strep equi, so running antibody levels on the blood are challenging to interpret. This test that we have available in the US is not perfect, and it cross-reacts with Streptococcus zooepidemicus, which is a very common bacteria in the horse's throat. And so it really is not a great test. So one thing I do recommend is making sure when you're in a situation you're wanting to diagnose strangles that people are sending in the right tests. Because I know that if the wrong test is run and everybody just spent money on all that tests, nobody is happy in the end if it doesn't give you good information. So work closely with your veterinarian, call the Diagnostic Lab, have them talk with them, and make a plan. These are schematics that were done by the group in Newmarket in the UK. And I think these are great little schematics on how to manage an outbreak. So basically what they're showing here is a few things. But one is they have this little horsey here. Actually, here, let's go here. We have the horse with the snotty nose. And this is the one, you know, a couple of the horses that started with the strangles initially. So those are the red horses. They have their little snotty noses, and all of them have bellgays. So those horses are separated from others, and they have clinical disease. Now you're going through, and you know that they were in contact with some other horses, but you're going to keep those separate, and you're going to be temping them. And you're temping them all the time, and here's their temps are normal. Uh-oh, this one here has a fever. It doesn't have any nasal discharge yet, but it has a fever. So you may choose to treat that horse before it develops clinical signs, or shift it over into the pen with the other ones with clinical disease. And now you're still monitoring these. And then hopefully your animals that had no contact at all, that were still on the farm, you're monitoring those, you know, a separate person is handling them, and they don't develop any fevers. But if they do, then lo and behold, they're going to get mixed up, put in with the clinical disease. So these in-contact animals, what they're doing here is showing that they're going to measure their antibody level when they first see them, and then they're going to measure their antibody level later on. And if they measure it later and it hasn't changed, then that animal has not been exposed in that time frame and will not develop disease, and you're okay to kind of forge ahead with plans for that particular horse. Now, I should say we don't have this diagnostic test available in the US and how they're using it. Our diagnostic lab is looking into that. I think it would be a more helpful test than the current one that we have in the US. So remember, antibodies are the proteins that our body makes when we're exposed to an infection. And when we first get exposed, it takes a couple weeks for that antibody level to increase. So that's how those things work. And then we can also use the same sort of testing for new arrivals on farms, you know, keeping them separate, testing them at the beginning and the end, and then if they're negative, then you're free to kind of put them back in with the herd. All right. So if we have, you know, strangles on our farm, like I said initially, some of it can persist in the environment. We're going to want to clean our waters, and also, like I said, you know, we're not going to trust the sun to get rid of things, so we're going to go through and do some cleaning and disinfection, like we talked about in our last talk. So remember, probably the waters, the halters, the top rail of fences are things that we're going to think about. And then as far as prevention goes, we do have some vaccines in the US for strangles. Like all vaccines, they're not perfect, and they do have some complications that I'll mention again. So there are two types of vaccines. One is the intranasal vaccine, which is called Pinnacle, and it is a Streptococcus equi bacteria that's been modified in the lab. So it's been shifted so it doesn't necessarily cause disease. And then we have another one that's been around for ages, which is a killed intramuscular vaccine. And we know that this one can cause abscesses in the muscle where we've injected it. So the intranasal vaccine works fairly well, although sometimes after we give it, the horses can seem like they have strangles. So, right, we've put kind of a modified bacteria up their nose, It's going to do some things in there. And so sometimes they can develop a mild lymph node enlargement, a mild fever. It'll look kind of like strangles, but it won't have the same sort of disease progression. The other thing about it is that whenever you give an intranasal vaccine to a horse, it's not necessarily fun, but they tend to snort all over you, right? So as soon as you squirt something up their nose, they're going to snort all over you. And so we know that if we put this bacteria in the horse's nose, it snorts all over us, and then I go ahead and give my intramuscular injection of my other vaccines, like the Eastern, Western, West Nile virus. If I do that after I've given the intranasal, I'm probably going to get an abscess where I inject. So I should always work to not give intranasal vaccines before I give IM injections. Meaning, if you're going to come and give vaccines, you could do the IMs 1 week and give the intranasals another. Or when you go to the farm, you give all the intramusculars first, and then you come around and give the intranasals second. So we certainly don't want to give abscesses into the horse's neck. In Europe, they have a vaccine that's a vaccine that they inject mucosally. So they actually, this picture shows them injecting it right into the lip. And we're still working hard on some other vaccines for strangles in horses. I'm sure there'll be updates on that. But the intranasal vaccine is, can help, has some complications. And I also had mentioned sometimes they can develop the Purpura Hemorrhagica secondary to the vaccine, but that's pretty rare. So who should you vaccinate? Well, usually the youngsters, because that's when they're going to be exposed the most. So 6 to 9 months of age, potentially pregnant mares to help protect the young as well, the colostrum, adult horses that are mingling, and then actually older animals sometimes can become sick from it because they may have been exposed as youngsters, they were vaccinated when they're youngsters, but they may be now susceptible. So I'm not saying to vaccinate the older animals. Sometimes they will have pretty high titers. They're more prone to developing the purpura, so you might want to be running titers before you're vaccinating those horses. The question always comes when you have a positive case on the farm, should I vaccinate everybody else? And I don't really have a good answer to that question. I would count more on the separation of the animals in the time of an outbreak, or when you've seen that first case. Basically, we know that when you're vaccinating an animal, it's not protected the day you give the vaccine, right? You give a vaccine, the antibody has a response. Often vaccines actually require 2 boosters in order to have protection, right? So that means a vaccine one day and another one 3 weeks apart, and then maybe they're protected a week or so after that. So generally, vaccinating in the face of an outbreak may not be helpful for you, and it could muddy the waters if you give a vaccine and the horse develops a fever secondary to the vaccine, which we know can happen. So if you're going to do it, keep track of it, talk with your veterinarian, make sure you have a plan, and make sure you discuss the pros and cons of each side of this. And then the other thing about strangles is that, just like anything, the best vaccine is actually natural infection. So if your horse has had strangles, chances are you probably don't need to vaccinate next year, but you'll have to vaccinate the year after. We don't really know how long the natural immunity lasts, so we still get worried and want to vaccinate them again. But probably you have a year or so until you need to do it again. I have a couple quick examples of cases that made me think over the last year or two, and I'll go through these with you. But basically, this is an example of an 18-month-old thoroughbred mixed breed horse. It was rescued and brought to a farm 2 months ago. The farm it came to was a closed herd, only 2 horses. It developed a fever this week, so 2 months after being in the field. The horse had thick white to green nasal discharge, big hard lymph nodes under its chin, and when I scoped its guttural pouches, it was full of pus, so guttural pouch empyema, which came back very, very, very positive for strangles. So my question was, where did the strangles come from? At the beginning of this talk, you remember we said the incubation period is generally 2 to 3 weeks, and this horse was on the farm for 2 months. So either the horse was sick sooner and the client didn't notice, or actually she may have a horse in her herd of the 2 other horses that's a carrier, and they're immune to it at this point, and this new horse became exposed and now is sick. So those were the 2 situations on this farm. Unfortunately, she was too far away from us to bring her other 2 horses in for testing, and I haven't talked to her since. Well, that one was a tricky one to kind of figure out. This is a 7-year-old standardbred gelding that came in for 1 month of fevers. And he had been on a place that had had a strangles outbreak. And I was like, no, he's already had his strangles. It's over. And I was like, well, okay. I bet you it's still strangles, but you can bring him in. We'll take a look at him. And he comes in the door, and he has, it's more highlighted because it's clipped, but you can see the swelling here right at his sort of throat latch region. It's a nice circular, hard, firm swelling. Looks perfect for strangles. So we ultrasound that, and we can see the abscess here. And remember, all these areas, we don't want to go monkeying around too much because there are some blood vessels. Another thing is that when we're ultrasounding things and we're pressing on it, we can make the blood vessels or the veins sort of not show up on our ultrasound screen. So the reason why I mention that is because this horse, we decided to open this up and let it drain because it had been such a long time. And unfortunately, we did hit the vessel as we were trying to drain the abscess. So maybe learn from our mistakes or know that there are many complications associated with how we treat these things. The horse did fine in the end, but it was a little scary at the time. And this is another one I had this spring, made me think quite a bit. Maybe Dr. Palmer will have some advice for me here as well. But we had this 11-year-old mixed breed gelding. He had 6 months of nasal discharge and more on the left. He's on the pasture. There's no other horses with him. And when he arrived to the hospital, he looked like this. And you can see that he has this very thick region right near the guttural pouch, right where strangles would be. But here's a horse that's been nowhere, exposed to no one, no thing. And he had strangles when he was 4 years old. And so this was an 11-year-old horse. 6 years ago, he had strangles. I don't know. Anyway, so we diagnosed him with guttural pouch strangles. He had tons of pus in his guttural pouch. They were chock full. We had to do surgery on them. They were just dried pus just filling that region. And I'm not sure if he had been chronically infected all that time and it just built up until he could take it no more, or whether he had exposure to other horses in the field or other people that brought it to him on his farm. He did okay in the end. Another example I just wanted to show you that's published in vet clinics in North America shows the value of these repeated testing. Although this is the nasal wash, and remember, we'd probably prefer to do the guttural pouch. And it shows why sometimes you want to do more than one of these things. So basically what they're doing is a PCR and a culture from a sample from the wash from the nose. And so on 2 occasions, this is July 21st, July 24th, the horse is negative, and the PCR is very low positive. And they're like, okay, well, I don't know. We're going to keep looking at the horse, and we get a bunch of positives. And then it goes negative. Let me think about this. And then we have 1 positive, and we have 3 negatives. So you can see how frustrating the testing can be for this farm, because now we're out to September 29th. So we're finally saying, like, listen, we're going to move this horse to a new yard, September 29th. Outbreak starts again on October 25th in the new yard. So the recommendation really is not necessarily to trust this nasal wash, that we may be better off with the guttural pouch washes, which unfortunately is a little bit more work and more expense for clients. But the second outbreak is a big expense as well. All right, so I guess I'll finish with that. Strangles is a difficult problem. The horses can get sick for a long period of time. There's lots of complications. It's hard to clear the infection from the horses and call your horses negative and allow you to compete with them in the future. It's worth prevention with the vaccine. And then I'd like to open the floor to any questions. Did you guys want to do questions? Have you had any experience with strangles? No? Cross fingers? Yep. Uh-huh. Mm-hmm. So you had one horse on your farm, you kind of isolated it, it ran its course in that horse, and you kind of had to keep things closed and yep. Mm-hmm. Yep. Mm-hmm. Yeah. Yeah, so sometimes you can kind of just have the one case and not have others get sick if the others are also protected and vaccinated and things like that. Mm-hmm. Okay. The question is, does 12 or 15 feet of separation mean anything? And one thing about strangles is it really is the pus and things like that. Whereas for influenza, the separation would not mean anything. For strangles, it does a little, although unless they're like snorting out the window of the stall or, hanging over the stall door and snorting around and stuff like that. So if they can snort and it can land in the next one's stall. But yeah, no, it's more of a kind of direct to indirect contact. But the more separation you have, the better off you are. But maybe you can get away with some stuff. Comments, Dr. Palmer? Nope. All right. You want me to do herpes? What's that? Okay, 15 minutes to wrap up for herpes? Okay. Mm-hmm. All right, so I saved the best to last, which is equine herpes virus, which is something near and dear to my heart because I've done quite a bit of research with Klaus Osterreiter and Bettina Wagner at Cornell University, looking at equine herpes virus, looking for new vaccines for equine herpes virus, learning about the neurologic form of the disease, and it's been a really fun ride. So I'd like to share some of our insights from that. So I'll skip through quickly for you. Equine herpes, we know it causes respiratory disease. Mostly EHV4 is implicated in respiratory disease, but we have EHV1 where they'll have a fever, and then we can have abortions and full death. And then we can also have neurologic signs where the horse can't bear weight very well behind. Usually it's associated with hind end weakness, ataxia, so kind of not knowing where their feet are going, and also they have difficulty urinating and defecating based on where it affects their spinal cord. It's a tricky virus because, again, it establishes latency, so horses are long-term carriers of herpes virus, and that it can be inhaled. though mostly we feel like it's a direct contact, so less aerosol and more of a kind of direct and fomite transmission. So basically the horse inhales the virus, okay? It goes to the horse's lymph node within a day or two, so these ones under their chin, and they'll seem a little bit painful at this phase as the lymph nodes are responding to the virus. And then what's special about equine herpes virus 1, unlike EHV4, which kind of stays in the horse's nose, this one gets into the lymphocytes that are your immune cells in your lymph node and starts circulating through the horse's blood. So this picture is a blown up picture of a lymphocyte, and then I have the herpes virus sitting in the middle of it. But just imagine that a whole bunch of these little lymphocytes are infected with the virus. They're going through the horse's bloodstream, and this is probably established about 4 or 5 days after infection. So after the horse inhaled it, this might be 4 or 5 days later. Now the virus is circulating the horse's blood, and it has a few places that it likes to go. It goes to the vascular endothelium, so the lining of your blood vessels is where it kind of, these cells talk to the blood, the cells that line the blood vessel, and then they become attached to it. And they cause a vasculitis, so they cause inflammation in the uterus, and then they also, for some reason, like the blood vessels of the spinal cord, and they cause a vasculitis in the spinal cord. So the virus has been circulating through the blood. The lymphocyte talks to the blood vessel wall. It becomes stuck there, and for some reason it picks, the blood vessels of the spinal cord. They're stuck there. They cause what we call like a thrombus. They have all kinds of inflammatory mediators that come in there. A clot forms, and then that clot in that particular blood vessel of the spinal cord is what makes for the clinical signs. Meaning, now if you have a clot in a blood vessel, whatever that nerve is going to, that nerve isn't going to work anymore. And so the thing that's similar to this is like a stroke in people. And so that's important to know because actually strokes in people, maybe a person doesn't get completely better depending on the severity of the stroke, but many times if there's a small blood vessel that's occluded, the blood supply could be returned, and then the horse can improve. So many horses can improve. And I learned that when we started doing some of these experiments because I thought, okay, well, if the horse has signs today, it'll be worse tomorrow and worse the day after. And that's not necessarily the case. Sometimes it can come on quickly, and then they can improve slightly. And many horses over the years we found, from the neurologic disease can return to normal function, but some don't. So basically then, in order to get the neurological signs or the abortion, we're going to be about a week into the whole disease process. But the other thing is that the horse is going to be shedding out of its nose. And we learned that lesson in 2003 with the outbreak in Ohio, Findlay. So that where a neurologic horse was brought into the Ohio hospital, and many horses became affected that were in that hospital. So now we're very cautious when we have neurologic horses to quarantine them to help prevent outbreaks. So if I was going to show you a graph of this is an experimental infection, if we have days and time and the horse's temperature, we give the virus to the horse here, and within 2 days, the horse has a really high temperature, and then 3 to 5 days later, they have another spike in their temperature. What's interesting is many times, and this is supposed to align with what we said, the viremia, so when the virus is going through their blood. Many times when I see a neurologic horse, the horse should be about this phase of the disease, so after this second fever spike, and many times clients will not have picked up on the fever in the horse. So that goes back to also thinking about when we have experimental studies, we're using horses that are non-vaccinated and very low titers, and so maybe we see something different in horses that are vaccinated and in the wild type. So when we first look at horses that are infected with herpes, this graph is meant to show you that in the beginning they have tons of virus in their nose. And so it's very easy to detect the virus in a nasal swab. The second part of this is looking at their blood cells to find virus in their blood. And the scale on the nose here is 10 to the 8th. So like, 10 million, 100 million. And over here, it's only up to 100,000. So way less virus is in the horse's blood. And so the take home from that is when you're trying to test for herpes, you want to send both a nasal swab and you want to send blood in as well. You might get a positive in one or the other, but you're really concerned about this for your farm, your training facility, so you want to know the answer, so you want to send in all the samples that will maximize your chance. We know it also causes abortions in horses, and I won't go in too much about abortions, but it is very significant for the thoroughbred breeding operations. And what's interesting too is that the mare may have no outward sign of illness, yet she aborts in her last trimester. And sometimes it can happen because the mare has just gone and sniffed another aborted fetus and the mare has an early infection, or the mare's own latent virus will be the cause for her abortion, and that's why she's never seemed sick to you. So it can be a latent virus or a new exposure that leads to these abortions. And so if the foal is born very close to term, it may be born alive and get rushed into an ICU, and then that horse's foal is extremely sick. Usually we're not successful at saving these foals, and sometimes the mares have what we call a red bag delivery. So these are the foals that are arriving at my hospital at like 4 to 12 hours of age. They really are very sick and tend not to survive. And we have a hard time differentiating these foals from other sick foals, except for if the farm has had a recent history of other abortions. This is kind of a gruesome graph from the University of Kentucky that shows over the years, back in the 50s to 2003, the number of abortions per 1,000 pregnant mares are in the blue bars. So lots kind of were happening. And then over time, the number of mares in the green line have increased, yet the incidence of EHV1 abortion reduced. And that was mostly due to husbandry practices that were put into place at the time where, you try to keep your resident farm animals very separate from the breeding farm operation, as well as vaccination. The neurologic disease has a range of clinical signs, but certainly the classic horse with neurologic herpes has a problem with the back end, so it's lumbosacral disease, and their tail and anal tone is bad. If they're a gelding or a colt, they might have what we call paraphimosis, where their penis is hanging out and they're not able to retract it. And you'll see them try to urinate and they'll be all wobbly, and they might even go down. There are other sort of, nerves. It can affect all the nerves. And this is showing kind of the stroke in the spinal cord where you see the black in all these different sections. These graphs show how the onset of the neurologic signs after getting infected. So if I look here, I see a purple horse here develop neurologic signs on day 6. And it gets worse on day 9, kind of stabilizes, and then kind of improves. One horse is really bad neurologically, a grade 3.5 on day 8, goes to 4, which means the horse is about to fall over. And then another horse that seemed to develop signs late. So the gist of this chart is really to show you it's about a week or so after infection that the horse develops neurological signs. And sometimes they start out really bad and stay bad. Sometimes they'll get a little bit better. And sometimes they'll only be mild. I'll do a quick mention of the neuropathogenic strain of the virus because this got a lot of press a few years ago. But my take home for this is that whether you have the neurological form or the non-neurological form, you should follow strict biosecurity measures to help control any problems. So basically what they did was they took some viruses that were from neurological outbreaks. So remember I mentioned Ohio 03. AB4 is one that I've used in experimental studies. Boy, I can't remember what year that was isolated. We had a New York outbreak in 05. So all these were linked with neurological cases. And then they have ones where they're only linked with respiratory or abortion. And they went through and they sequenced a portion of the virus, the ORF30 region. So it's not the whole virus, but they sequenced this part. And they found one gene mutation. So one gene was changed, which then resulted in a change in a protein that's made by that virus. So it changed to a protein that we'll call the D protein for disease. And then the ones that don't necessarily cause neuro are the Ns. Interestingly enough, other herpes viruses like E24, this is the varicella zoster virus, which is for people. Most of the time, herpes viruses have the D form, which is where the neurologic thing is. And we know herpes likes to live in horses. It doesn't live in the environment. So, what would be the advantage ever for it to cause neurodisease and kill the horse? We're not exactly sure. So we feel like this virus keeps the horse infected for longer, like their virus load in their blood is longer and a higher amount. And so that's why we think it's more likely that it crosses over into the spinal cord and causes neurological signs. And so to prove the point about the importance of the two different viruses, I did a study with our Diagnostic Lab looking at about 30 years of isolates that came to our lab. And we knew from the histories that they had had neurological signs or respiratory or abortion. And by far, most of the samples that came to the Diagnostic Lab were from abortions and respiratory disease, mostly abortions. And then we looked at the sequences of the disease, so the neuro ones, the D752, and then the non-neuro ones, the N752. So mostly the abortions were caused by the N752, and mostly the neuro disease was caused by the D, or the neurological form. But lo and behold, we have a total of 21 isolates from neuro outbreaks, and 5 of them were from the non-neurological form of the disease, which I can do math well enough that, 5 of 20 is about 20% here of the cases were the non-neurological form. So it's still important, if you have the non-neuro type, to follow some biosecurity protocols. And I think that became quite critical to us years ago when the diagnostic test became readily available to just test for the neurotype. And people were like, it doesn't matter if it's a non-neurotype. Well, it does matter, and you should take the same sort of precautions. Okay. And then since then, a lot of people have done studies and proven the same thing, that the neurological form of the virus has been around for ages. They found it in isolates that they had gotten from horses in Kentucky back in the 50s. So it's been around. It's not necessarily new. So I say, some people see a group of horses. I see herpes virus. Horses carry herpes. They get exposed early in their life. And many horses probably have the N form of the virus. And there's like yellow N's and, pale yellow N's is my interpretation of this. And then chances are there's a horse out there with a D. Our estimate is probably about 10 to 15% of horses may be carrying the D, but we don't know that for certain based on our type of tests that we can do. And then there might be another N that's kind of a white N. But horses are carrying herpes virus, and it's in their hiding, they're latent, it's in their nervous tissue, and when they're stressed, they can start to shed it again. So the concern often, I'm stressing this. Okay. So the concern often comes from people who have had a horse that's neurologic with herpes. It's in my hospital, and they say, well, it can't go back to the farm. It's carrying that virus. And it will be carrying that virus, but many other horses will be carrying that virus, and you just don't know it. So, the question I often get is, should you euthanize the horse you just saved from its neurological condition? And my answer to that is no. That horse shouldn't necessarily live in a glass bubble. It shouldn't be euthanized because it's a carrier. There are many other carriers out there. They've just not been diagnosed. So the epidemiology, the horse is young. It's infected as a youngster. A latently infected mare reactivates her virus when the foals are by her side. The young foals get infected. They're recruited. It lives in the horse, and the cycle continues. So that's how equine herpes virus works. A few key things to polish this up, because I know we didn't have too much time here, but the transmission is really this kind of mostly direct contact, maybe more aerosol, but herpes is a virus that lives in the horse and has been for centuries. And it does not persist in the environment. It might live a day or two, but it's not going to stay in the environment. So cleaning and disinfection, it's important to always be clean, but you don't have to empty the barn out and do a full cleaning and disinfection. However, you're welcome to do so. You can use a regular soap. It's very susceptible to disinfection. The horse, though, is where the virus is and what you need to pay attention to. So it can be direct nose-to-nose contact. It can be droplet mostly. There's still question whether it's aerosolized. We don't think so, because they really don't have this explosive cough like the influenza does. And the risk is related to the amount of virus that's in their nasal secretions. And for sure, the placenta and the fetus of an aborted fetus is highly contagious and needs to be handled with strict precautions. So we've gone through some of these fomite transmissions already today. So all these things can, take the virus from one place to another. Our best way for testing, I mentioned, was the nasal swab initially and sending in blood. Work with the diagnostic to pick the best diagnostic lab to pick their best test. But a PCR will be the most sensitive way to find it. So how do I recognize a horse that's shedding herpes? Well, there can be an inapparent shedder, so a healthy horse that's just got some virus, and you don't know, not sick at all. It could be a horse that has a fever in the respiratory form, and that's why you want to contact your vet right away when your horse has a fever. And then it could also be a neurological case that's shedding then as well. And then a question, we don't know a lot, but we know that the foal and the placenta of an aborted fetus are very high in virus. And what about the mare's vaginal secretions? If we're flushing these mares after they've had an abortion, we probably should be wearing personal protective gear, disposing of those fluids carefully so that we're not exposing other mares. This is a reportable disease in our state. Most of the time we'll end up closing things, temping horses, the usual sort of biosecurity protocols, and seeing, if a fever spikes soon. The incubation period is not very long, only a few days, so you'll be seeing the cases in short order. We can treat horses with acute herpes infection if they just have a fever. Anti-inflammatories, rest. There's question, deciding whether you want to use antivirals like valciclovir, or anticoagulants have become kind of the thing that maybe is helpful in these neurological cases. Remember, it's sort of like a stroke and a thrombus or a clot, and if we can prevent that clot from forming, we're less likely to have these clinical signs. So we got to do a lot of supportive therapies, as I've mentioned this already. And then the valciclovir seems to be the drug of choice based on its absorption. Now, I must say that once the horse has had neurological disease, I believe that the antivirals are probably not all that helpful, because remember the time frame I said, it's already been in the horse's blood and gone to the spinal cord. Chances of us stopping it are pretty slim. So maybe more in the in-contact animals is where this becomes helpful. They are expensive, although sometimes, depending on drug availability, the cost could be somewhat reasonable, but a lot of people try anti-herpes drugs. There are many vaccines for horses. We should be vaccinating for EHV1. I often think, why would we vaccinate something that the horse is latently infected with? It doesn't make sense. The horse probably already has herpes virus. But my reasoning to it is that what you want to do is keep the horse's immune system really strong so that it keeps that virus hiding in its body in the nervous tissue and not shedding. So you want the immune system to kind of like keep walking around the perimeter of the horse, basically the fortress, keeping it inside the horse and not allowing it to shed. So vaccine is important for management of herpes. It's not perfect. It doesn't prevent all infections, but it certainly does reduce disease severity and incidence, and we know that. So we're at the end of our herpes talk. If anybody has any questions, I for sure could talk for hours about herpes. And I tried to be 15 minutes, but it was probably longer. But if anybody have any questions, I'm happy to talk about equine herpes virus.
For the next hour, I'd like to visit with you about appropriate use of medication at the racetrack. Now, when we go to a movie theater, we're often suspending our credibility, just suspending our imagination for a bit. I'd like you to think about the use of medication at the racetrack in ways that are different than you might ordinarily feel about such matters. For example, I want you to think a little bit about what it is that we actually do at the racetrack. Are we a gambling business? Are we a professional sport? Are we in the entertainment business? Who are our customers and what is important to them? These are questions that are very, very important to us as an industry because we do not do this work in a vacuum. We need to think about who it is that is our competition, what is it that sets us apart from that competition, and what are the existential threats that limit our success or growth as an industry. We also need to think a little bit about the parimutuel environment, which is a unique environment in which we work. It's a highly regulated environment in which gambling and horse racing occurs. The financial pressure upon stakeholders is enormous, and public scrutiny is intense. But all financial considerations aside, animal welfare issues present a unique challenge to the horse racing industry. Owners, veterinarians, and trainers are faced with unique, challenging ethical choices. The question of what is good for the horse is good for the industry has profound implications for the way we do our business. The elephant at the doorstep is the presence of animal rights and animal welfare organizations that stand outside this racetrack every weekend and protest horse racing. The question is begged, does horse racing represent animal abuse? Some people say yes, some people say maybe, some people say no. Certainly, most people in this room would say no. But when you ask the general public that question, you have to say to yourself, well, does medication have any impact on your decision? Or do racing injuries impact your decision about how you feel about horse racing? These are very important questions. An NTRH survey in 2008 addressed this issue And three top concerns emerged among thoroughbred racing fans. The number one concern was the health and safety of the horses. The number two concern was the use of performance-enhancing drugs. And the third concern that they talked about was therapeutic overages at the racetrack. McKinsey's report in 2011 discovered similar results in their market research. They pointed out that the concerns over animal safety and welfare and medication were consistent themes in their consumer research. In fact, nearly 80% of racing fans indicated in this study that they would stop betting if they knew that horses were not treating well, including concerns regarding thoroughbred safety. Nearly 40% of racing fans said that they would bet more if they knew that the horses were not being given drugs. So this is an enormous problem in horse racing. There's a stigma attached to it that we need to address if this industry is going to survive and thrive in our current demographic environment. This is not a problem that's unique to horse racing. This is a problem that exists in all of professional sports. The list that you have here in front of you is a list of popular athletes who have recently made the headlines because of the use of drugs, whether it be blood doping agents, anabolic steroids, hormones, or growth factors, to gain a competitive advantage. This past winter, Russia was banned from the Winter Games by the International Olympic Committee, and this was done because the IOC determined that Russia had executed an extensive state-backed doping program. As a result of this, they issued historic penalties. It included banning the Russian team from the 2018 Winter Games in South Korea. No Russian officials were allowed to attend. The Russian flag was not displayed, and the anthem was not played. It's very clear that public medication plays a major role in how people feel about the use of drugs in sports. Most of us grew up with a culture of just say no, that sports and drugs just don't mix. Drugs have no drugs should not be in sports in any way, shape, or form. I'm sure the picture that you see in front of you now you'd recognize as probably one of the most famous cycling athletes of all time, who was discovered to have been using blood doping agents regularly during his Tour de France races. And there have been profound implications for Lance Armstrong because of this. And it's just an iconic example of our society and how intolerant it is of the use of medication in sports. With all that said as a background, then, it's pretty clear that there's a public mandate felt by racing officials to reduce the amount of medication that's being used in horse racing in North America. Medication in horse racing can be looked at from a couple of different angles. While the general public views medication through the lens of drugging, trainers and veterinarians view medication through the lens of sports medicine. Are these views mutually exclusive? How can they be reconciled? To get a handle on the scope of the problem in horse racing, I'd ask you to think about these questions. How many of your horses are being treated with some form of medication? How many of these medications were prescribed by a veterinarian who actually has a working knowledge of your horse's health and condition? How many of these medications were prescribed for treatment of a specific medical condition? When we think about medication at the racetrack, it's helpful to consider who is actually administering the medication. Certainly the attending veterinarians are the primary sources of medication for the racehorse. Regulatory veterinarians occasionally administer medication to horses. In particular, regulatory veterinarians administer Lasix or Salix to horses before they race. Trainers administer certain medications to horses that are dispensed to them. And stable employees at their direction also administer medication to racehorses. Who regulates medication at the racetrack? Well, currently, there are 3 regulatory bodies involved. There are state statutes that regulate the way medicine is practiced. There are New York State Gaming Commission regulations, and there are House rules. On the horizon is the possibility of proposed federal legislation. It's beyond the scope of this talk to get into any details about that. But suffice it to say that if federal legislation actually takes place, it would supersede the state regulatory bodies and the local racetrack. The state law refers to the Department of Education, Board of Veterinary Medical Examiners. They regulate the practice of veterinary medicine in the state of New York, which covers all medication given to all animals in the state. The New York State Gaming Commission regulates the use of medication specifically at New York State racetracks. NYRA regulates some procedures as well. For example, shockwave therapy. NYRA veterinarians administer furosemide as part of a third-party LASIX program. NYRA also samples horses for out-of-competition testing. NYRA veterinarians examine horses before they race. So what are the priorities for medication use in horse racing? Well, there are really 4 priorities. And right at the top of the list needs to be equine health and welfare. The safety of horses and riders is also critically important. The integrity of the sport, and then optimizing performance. The veterinary paradigm is that veterinarians view their role as sports medicine doctors for horses. This role has 2 dimensions. First and foremost is to provide for the health and welfare of the horse. Second is to ensure that the horse is in top medical condition prior to competition. The trainer paradigm is very similar. Trainers can be viewed as coaches, if you will, of a professional athletic team. And this role has 2 very similar dimensions. First and foremost is to provide for the health and welfare of their athletes. Those would be the horses. And second is to ensure that those horses are in top condition prior to competition. When we talk about medication, it's important to understand that all medication is not the same, and that medication can be used for a variety of purposes in sports. The purpose for which the medication is used influences our perception about how appropriate or inappropriate that treatment may be. For example, preventive medication is administered to prevent disease or parasitic conditions. I think we could pretty well, all of us, agree that there's really nothing wrong with administering this type of medication to racehorses. But how about this? How about therapeutic medication that's administered to treat infections, medical conditions, or injuries? Well, I think, again, most of us would agree that if a horse gets sick or a horse gets hurt, that medicine can play a critical role in restoring that horse to health. Now here we get into a little bit more difficult choice. When we talk about pre-race and post-race medication, that's medication that's administered in close proximity to a race. That medication, when it's administered to ensure the best possible performance of the horse, and also to speed recovery from a race, that becomes a slippery slope. This is where most of the controversy occurs. Is being in a race a medical condition? Well, clearly it's not. Clearly it's an event that we certainly want the horse to be in its top form to compete in that event, but it is not an illness, it's not a disease. So when we think about these medications that are given in proximity to the race, again, some of these are more important than others. Pain management is the primary area of concern. Are we putting horses at risk by administering pain management medications within proximity to the racing period? Now, there already are regulations in place that limit the amount of pain medication that can be given in proximity to a race, and this has greatly helped pre-race examinations, helping to show us the true nature of the horse's condition prior to the race, as long as there is not painkillers in the horse's bloodstream that would complicate that examination. In particular, we are concerned about the appropriate use of nonsteroidal anti-inflammatory drugs and corticosteroids in the racehorse. The administration of nonsteroidal anti-inflammatory drugs or intra-articular injections of corticosteroids to treat inflamed joints is a medically justified and appropriate procedure. However, problems can arise when those treatments are performed either in the absence of a clinical diagnosis or without the opportunity to evaluate the outcome of that treatment prior to the race. Additional problems can arise from the administration of analgesic medication during training, to the degree that the trainer may not be able to accurately determine the true soundness of the horse between races if there is medication in effect. So how do we resolve this dilemma? We have medication that we know is appropriate to give to the horses. We know that all athletes have aches and pains, and some medication is helpful to manage all of that. But we need a guiding light. We need a guidance about how to make appropriate decisions to decide what type of medication should be used in these horses and when it is not appropriate to do so. I believe the key to this dilemma is simply to keep the health and welfare of the horse uppermost in our minds when we're making these decisions. The AEP back in 2008 published a document called Clinical Guidelines for Veterinary Practice in a Parimutuel Environment. This document was specifically written to address these issues and to help provide guidelines for veterinarians to make appropriate decisions about the use of medication at the racetrack. A core concept in this document is that all medical treatments of the racehorse should be, one, based on a veterinary diagnosis, and two, the appropriate time following the treatment or injury to ensure that the horse is recovered prior to racing. For example, the best practice for intra-articular therapy includes the administration of a combination of medications. The first is a symptom-modifying medication. That would be a corticosteroid. Usually it's betamethasone or TCA. Combined with a disease-modifying medication, which could be hyaluronic acid, polysulfated glycosaminoglycans, polyglycan, or IRAP, for example. But the combination of a short-acting steroid and these disease-modifying drugs is really the state-of-the-art for managing intra-articular injuries. For reasons of economy and convenience, some trainers and veterinarians have become mired in a paradigm of injecting joints after entry into the race. And this creates problems because for two reasons. The first thing is that when you do that, the time that you have between the treatment and the race does not provide for a maximum effect of the drug to take place, nor does it provide any opportunity to evaluate the therapy before the time of the race. And again, the fundamental question should be answered out of competition, not at 38 miles an hour on the racetrack in the company of other horses and riders. You know, is this horse now fit to run? Welfare-centered regulations are a priority for regulators. Regulators strive to enable veterinarians, as sports medicine doctors, to have the opportunity to perform ethical and appropriate professional services that put the safety and welfare of the horse first, while still serving the best interest of owners, trainers, and the sport of horse racing. A dependency upon performance-enhancing medication in all sports is in direct conflict with the cultural norms of our society. Decreased use of medication in sports is the way to the future. This is a cultural change focused upon equine welfare that will provide the path to sustainable growth in the horse racing industry. So I'd like to leave you with a discussion point, something to think about. Again, how do we define the appropriate use of medication in the racehorse? On the one extreme, we have the viewpoint that medication has no place in sports. On the other side of the coin, we know that medication is necessary to treat sports injury. Again, how do we reconcile these two conflicting points of view? And once again, I would reiterate that I believe the answer is putting the health and welfare of the horse uppermost in our minds, because I do believe that what is good for the horse is good for horse racing. And we'll refer back to the very beginning of the talk today and reflect on the comments that I made about what is it about our business that makes it unique. What discriminates horse racing from all other forms of gambling and entertainment and sports? And that is really the horse. Without the horse, we have no industry. Without the horse, we have no sport. The horse is our priority, and we need to take care of him with our good medication policies. Thank you very much, and I appreciate your attention. In this next session, we're going to talk about prohibited substances and methods. Now, in the first part of this talk, in the earlier session, we discussed the appropriate use of medication at the racetrack in a broad sense. We talked about cultural norms and changing demographics in our society and how that influences our business model. And now we're going to focus a little bit on one particular type of medication, one particular area of medication that is particularly problematic in terms of medication that is on that slippery slope that we talked about in terms of enhancing performance rather than treating a medical condition. So, the first thing I'd like to just spend a little bit of time on is talking about the organizations that regulate and characterize medication use at the racetrack. The Association of Racing Commissioners International is an umbrella organization of the official governing rulemaking bodies for professional horse racing, greyhound racing in North America and parts of the Caribbean. Now, not that we're going to spend any time at all talking about the Caribbean or talking about greyhound racing, but the ACRI, or the RCI as it sometimes is called, is a very important piece of medication use and medication regulation at the racetrack. The RCI sets standards for racing regulation and medication policy. They also provide uniform classification guidelines for medication according to the specific properties of each drug. Medications are ranked by the ARCI based upon a number of factors, including pharmacology, the ability to influence the outcome of a race, whether or not they have a legitimate therapeutic purpose, or other evidence that they may be used improperly. Drugs that are potent stimulants or depressants are placed in the higher classes of medication, while those that have little effect on the outcome of a race are considered to be less of a threat to the industry and are placed in lower classes. Drugs that are clearly not intended for use in the horse are also placed in higher classes, while those with legitimate therapeutic indication are placed in lower classes. Finally, the ability to influence the outcome of a race may be either a mitigating or an aggravating factor in the classification ranking. So if a drug has a very high ability to influence the outcome of a race, particularly if it's a stimulant or a depressant, that drug is going to be put in the higher classes than one that is not so powerful, if you will. So if we look at take an overview look here at the uniform classification guidelines used by the ARCI, Class 1 drugs are drugs with a very high potential to affect performance and generally have no accepted medical use in the horse. Class number 2, these are drugs with a high potential to influence performance, but have less potential to affect performance than drugs that are in Class 1. Therapeutic drugs with less potential to affect performance than Class 2 drugs And Class 4 drugs are therapeutics with less potential than Class 3. And finally, Class 5 are therapeutics with very little ability to influence the outcome of the race because they have very localized actions. For example, Class 5 drugs are the anti-ulcer drugs. So a totally separate category, the ACRI categorization of drugs are prohibited substances or prohibited practices. So prohibited practices are defined by the ARCI as the possession and or use of a drug, a substance, or medication for which there is no analytical method to detect or confirm the administration of substance. So obviously, we don't want drugs being used in racing that we can't detect. A second category for prohibited substances or practices is the possession or use of a drug, substance, or medication that has not been approved by the United States Food and Drug Administration for use in the United States. Finally, the practice and administration or application of a treatment, procedure, or therapy that may endanger the health and welfare of the horse or endanger the safety of the rider or the driver, or the use of which may adversely affect the integrity of racing. So these all are categories of drugs that are listed as prohibited substances by the ARCI. On July 16, 2018, the New York State Gaming Commission approved an amendment of Section 4043.12 of the New York Code's Rules and Regulations that forbids possession or use of a substance or method listed in the ARCI prohibited list and added another section, 4043.16, that forbids any drug administration to a thoroughbred racehorse except in the context of a valid veterinary client-patient relationship. Now, the ARCI prohibited list can be found in the model rule ARCI 11-015 version 7.0. This rule was approved by the ARCI in their meeting of December 9th in 2016. In this list of substances, which is extensive, and a lot of them were taken from WADA, the World Anti-Doping Agency, or the USADA, United States Anti-Doping Agency list of prohibited substances. A number of these medications that are listed on this list are exempted from being prohibited as long as their administration complies with an ARCI required conditions for restricted therapeutic use, or RTU. So in other words, even though some of these substances are prohibited, we believe that they're still important enough for the maintenance of health and welfare of the horse to have some opportunity to use them as long as certain conditions are met. So what is an RTU and how do I get one? A restricted therapeutic use is a specific condition that must be met to permit administration of an otherwise prohibited medication to a racehorse. And not all restricted therapeutic uses are the same. For example, some of these medications are allowed to be given to horses, but that the administration of the drug has to be reported if the horse is going to be sampled in out-of-competition testing. So specifically, the rule reads, the administration of a substance must be reported to the commission when the horse is next sampled if the horse is sampled within 24 hours after administration. For example, IRAP, interleukin-1 receptor antagonist protein therapy for arthritis, is one of the medications that must be reported if the horse is going to be sampled. Another condition for an RTU might be a pre-filed treatment plan. That is, a treatment plan of the substance must be filed with the commission by the time of administration in a manner approved by the commission. Now this particular restricted use exemption is specific to California. In California, veterinarians that work on the racetrack submit a list of confidentials every single day. This is a list of every single horse that they treat on the racetrack is provided to the Commission on a daily basis. At this time, this is not done in New York, so this particular RTU is not applicable to New York State. Written approval. Some of these medications require that the Commission grant approval of a written treatment plan before the administration occurs. This approval plan must meet specific criteria as described in the New York State Gaming Commission's Equine Medical Directory Advisory of July 30, 2018, which is available on the Commission website at www.gaming.ny.gov under the horse racing section and then under equine health and safety. For example, thyroxine, or T4, for the treatment of hypothyroidism is one of the medications that requires written approval with this new rule in place. What about emergencies? Well, emergency use means that the substance that had to be administered due to an acute emergency involving a threat to the life or health of the horse. The administration must be reported to the Commission as soon as practical after the treatment occurs. For example, blood replacement therapy may be required to treat a horse that's experienced acute blood loss. Another condition is that nearly, I guess all of the drugs that are on this list have to be prescribed by a veterinarian. The attending veterinarian has to do this in a manner that's consistent with standards and procedures of the Veterinary Medical Practice Act in the jurisdiction in which the horse is located. Obviously, that would be New York in this case. Albuterol is a bronchodilator that's commonly used to treat respiratory conditions, and this is one of the drugs that is required to be prescribed by a veterinarian. Reporting of treatment. This RTU specifically says that treatment must be reported to the Commission with information for the veterinarian's list. The trainer may delegate this responsibility to the treating veterinarian, who shall make the report when so designated. Nandrolone, which is an anabolic steroid, is one of these drugs which may be given to racehorses, but the treated horse will be placed on the vet's list for 6 months before it can race. There are a few other specific limitations, additional requirements, if you will, that apply, such as a substance may be used only in fillies and mares. For example, altrenogeст or Regumate for the suppression of estrus. What about unapproved drugs? What about drugs that are not on the list? Well, these new rules will prohibit the administration of any unapproved FDA drugs. These are substances that are not approved by any government authority for human or veterinary use in the jurisdiction of the horse. This prohibits the use of drugs that are either under development or have been discontinued, and it prohibits the use of synthetic drugs that are altered to evade detection. This rule does not include vitamins, herbs, and nutritional substances that do not contain a prohibited substance. This rule also does not preclude clinical trials for medication as long as it's approved by the Commission. So that's pretty much a summary, a generalized summary of the RTUs and the prohibited substance rule that just went into place. There are some serious penalties that will be administered for unlawful possession or administration of prohibited substances, including placing the horse on the steward's list and possibly revoking the violator's racing license. On the same day, another part of the rule amendment for the New York State Gaming Commission was a new section of the New York Codes and Regulations rules that forbids any drug administration to a thoroughbred racehorse except in the context of a valid veterinary client-patient relationship. Now, what is a valid veterinary client-patient relationship? How do we define that? Well, there are really 4 criteria that have to be met. The first of which is the veterinarian who is administering the treatment has accepted responsibility for making medical judgments about the welfare and welfare of the horse. The second condition is that the veterinarian has sufficient knowledge of the horse to make a preliminary diagnosis of any medical condition that might be present. The third condition is that the veterinarian has performed an examination of the horse to make a preliminary diagnosis. And finally, the veterinarian is available to evaluate and oversee treatment outcomes, or has made appropriate arrangements for continuing care and treatment. So all four of these conditions have to be present in order for there to be a valid veterinary client-patient relationship, which is now a requirement for the administration of any medication to a thoroughbred racehorse in New York. Now, there are a number of parts to this particular rule, but again, the first one, Part A, says, again, no drug may be administered except in the context of a valid veterinary client-patient relationship between the attending veterinarian, the horse owner, who may be represented by the trainer or another agent, and the horse. The owner is not required to follow the veterinarian's instructions, but no drug may be administered without a veterinarian having examined the horse and provided a treatment recommendation. This falls back to the AAP guidelines that we talked about in the earlier presentation, where one of the first criteria of the appropriate use of any medication is that there be a veterinary diagnosis of some medical condition or problem. Part B of this regulation refers to the fact that no prescription drug may be administered except as prescribed by an attending veterinarian. Finally, the trainer and veterinarian together are both responsible to ensure compliance with these limitations on drug treatments, except that the medical judgment to recommend a treatment or to prescribe a drug is the sole responsibility of the veterinarian, while the decision to proceed with the treatment is the responsibility of the owner or his agent. This relationship is maintained by veterinary visits as needed, and the medical judgments of the veterinarian must be independent and are not dictated by the trainer or the owner of the horse. So, interesting. These are actually guidelines by the New York State Department of Education Board of Veterinary Medical Examiners that have been in place for quite some time in New York. But what this new rule does is make sure that that relationship is present when veterinarians are treating horses at the racetrack. So how will these new rules affect me? Well, it really depends upon the type of medication that your horses are being treated with. For example, if you do not administer any substances that are on the ARCI prohibited list, this new rule will not affect you at all, other than the fact that you need to have a veterinary input for medicating your horses. The following slides will describe the impact of this rule on the administration of a wide range of possible treatments. First of all, if you're administering anabolic steroids, boldenone, nandrolone, testosterone, while these treatments are allowed, they must be reported to the commission, and the horse will be placed on the vet's list for 6 months. So what this does is it recognizes the value of using anabolic drugs to treat debilitated horses, for example, but by the same token, those debilitated horses don't belong on the racetrack. All blood-related treatments and infusions, these would be blood transfusions, are prohibited except in an emergency. If a horse is sampled within 24 hours of blood therapy, the treatment must be acknowledged at the time of sample collection. How about clenbuterol? Well, clenbuterol use is not prohibited when used in compliance with the existing New York State Gaming Commission rules, which include a 14-day restriction from racing, and as long as the ARCI threshold is not exceeded. Diuretics. Except for furosemide and trichloromethothioazine are now prohibited, but may be used in emergency. If the horse is sampled within 24 hours of treatment, the administration of these diuretics must be divulged at the time of sample collection. Altrenoget, or Regumate, is now limited to administration to female horses for the control of estrus. All hormone and metabolic modulators, except for thyroxine, are now prohibited. Thyroxine, or T4 treatment, requires written approval from the New York State Gaming Commission. The treatment plan must specify one horse, the dose, the duration of treatment, the specific diagnosis, and the basis for prescribing thyroxine. What's more, the thyroxine container must be labeled to identify the individual horse, the dose, duration, and the estimated last administration date, and contain only the prescribed amount of thyroxine. Gene doping agents with the potential to enhance performance are now prohibited, except for IRAP and PRP do remain permitted. Only if the horse is sampled within 24 hours of treatment, the administration must be divulged. Mesenchymal stem cell treatments must also be reported to the New York State Gaming Commission. If the horse is sampled within 24 hours of treatment, the administration must be divulged at the time of sample collection. Nucleic polymer transfers, the transfer of nucleic acid or nucleic acid analogs, something I'm sure you're not doing right now, but it's something that's out there in the future, will require written approval from the Gaming Commission, and treatments must be reported to the Commission. Chorionic gonadotropin and luteinizing hormone are now limited to the treatment of undescended testicles in intact male horses. This treatment requires written approval from the Gaming Commission. Treatment must be reported to the Commission, and the horse will be placed on the vet's list for 60 days. The treatment plan for the use of unapproved drugs must specify the following. First, this has to be a generally accepted therapy. Second, there has to be a significant health benefit for the horse. Third, no reasonable therapeutic alternative exists. And finally, no performance enhancing, that is beyond normal healthy performance, effects will result. So again, how will these new rules affect me? Unless you're administering ARCI prohibited substances to your horses, this rule will not affect you at all. A few treatments that were previously allowed are now prohibited. Prohibited substances used in a legitimate therapeutic context will now require documentation and permission by the Commission in some cases. And finally, a veterinarian must be involved in all medication decisions. Now, these new rules were put in place on July 16 in 2018, and at this point, the enforcement of these rules is being pushed off just a little bit to give everybody a chance to understand them and how to work with them. We also need to generate a little bit of paperwork for the reporting process, but these rules are in place right now. And if you have any questions about them, you can certainly contact me or refer to the Commission website at www.gaming.ny.gov. Thank you very much for your time and attention.